Welcome to our second half of the ankle and lower leg presentation. In this presentation, I'm going to discuss how to prevent ankle and lower leg injuries. But the majority of the time is going to be discussing how injuries happen, which is called MOI, or mechanism of injury, MOI. What are the different signs and symptoms for each one of these injuries, and what is the treatment, or TX, for each injury. Now, on the exam, when you start taking exams with all these different injuries, the thing that you're going to have to remember is what makes, if I list a scenario where I provide some signs and symptoms, you have to figure out what injury it is, or I give a particular name of an injury and I'll list some signs and symptoms and which one are the correct signs and symptoms for that particular injury. First, let's talk about how we can prevent ankle and lower leg injuries. First thing is very important, stretching the Achilles tendon. It's good to stretch it both with the knee extended and the knee flexed 15 to 30 degrees. On the pictures on the left hand side, we have the common Achilles tendon stretches, the towel stretch, the standing calf stretch, and then the standing soleus stretch is the one I'm talking about with the knee flex 15 to 30 degrees, because that isolates the soleus muscle in the gastrocnemius soleus compartment. Other thing we need to do is strengthen the muscles around the ankle and the lower leg. So the calf muscles and all the other muscles that we talked about in the other presentation. You need to make sure those muscles are nice and strong. Develop neuromuscular control, which that is the ability to adapt to uneven surfaces. There's a whole bunch of exercises and rehab you can do on developing neuromuscular control that you can look up on Google. Wearing the right shoes for the right sport, and make sure that they're fit correctly. We have come a long way in footwear over the years, so it's critically important to wear the right shoes. Not only will this help prevent ankle and lower leg injuries, it'll also help prevent back injuries too. Last thing is preventative taping and bracing. You'll be taught how to do various tape jobs, especially the ankle tape job. But that is another way that we can limit the severity of the injury when it happens. That's the purpose of an ankle tape job, is to limit the severity of that ankle sprain. Speaking of ankle sprains are the most common ankle injuries, one of the most common injuries in athletics. Probably, I would say 50 to 80% of most of the injuries done in a typical college or high school are ankle sprains. And the most common of these are what's called a lateral ankle sprain, because they happen to the lateral ligaments. So the mechanism of injury is, there's three different ones. We have where somebody is plantar flexed or inverted their ankle. This is when you step on somebody's foot. Roll your ankle is another way this is thought of, as you can see in those pictures. The ligaments that are involved when we have plantar flexion or inversion are the anterior talar fibular ligament, the calcaneal fibular ligament, or the posterior talar fibular ligament, the three lateral ankle ligaments with this motion. If somebody just has straight inversion, they're not in plantar flexion or dorsiflexion, they're neutral, and they do inversion, that's typically just the calcaneal fibular ligament. If somebody does dorsiflexion, so their foot is all the way extreme hyperdorsiflexion, that's going to involve the tibial fibular ligaments. This is when somebody lands really hard on a hard surface and their foot is jammed really high up in dorsiflexion. This is what's called a high ankle sprain. So when you hear that term used on ESPN or whatever sporting thing that you listen to, somebody just suffered a high ankle sprain. That's the anterior and posterior tibiofibular ligaments. Those are the ligaments that hold the tibia and the fibular together. So when we're talking about lateral ankle sprains, we're going to talk about how we grade them. So here's a picture I think does a decent job of kind of explaining in 3 different grades of ankle sprains. Grade 1, the muscle, or sorry, that's not a muscle, that's supposed to be a ligament. Again, a ligament and sprains go together. Muscles and tendon tears are strains with a T. So sprains, grade 1, the ligament has a little bit of tearing. Grade 2, got a pretty significant amount of tearing. Grade 3 is a complete rupture. The other way that I've been taught about these, grade 1 has anywhere from 1 to about 20-25% of the ligaments torn. Grade 2, the ligament is torn anywhere from 20 to 75% of the ligaments torn. Grade 3, again, complete rupture, 75 to 100%. Typically, it's completely ruptured. Other way I've heard of this being done in the ankle, grade 1 is just the anterior talar fibular ligament. Grade 2 involves anterior talar fibular ligament and the calcaneal fibular ligament. And a grade 3 is all 3 of the lateral ankles are ruptured. So just so you know, that's kind of how it's done in the medical community. So grade 1, most of the symptoms are pretty mild. So we have a little bit of pain, swelling, point tender over one of the ligaments typically. Typically it's going to be the ATF. They have some pain with walking or weight bearing. That's what WT stands for, weight bearing. So they can still walk. We can probably tape them up and get them back in the game. But the typical treatment here is price, the protection, rest or restricted activity, ice, compression, and elevation. Now we use this thing called a horseshoe pad. So we use foam padding and cut a U shape out of it, stick that there by the lateral malleolus, then use an ace wrap or a tape and wrap that up there. What that does, it keeps the swelling from sitting in that natural part of their body, because the problem again with swelling is if we don't control it, the swelling takes a long time to get rid of. So we use this horseshoe padding a lot with ankle sprains. So continue on with grade 2. Here's a nice picture of a grade 2 ankle sprain. So the athlete actually feels a pop, snack, or click when they roll their ankle. They're going to have more severe point tenderness, pain and swelling. Typically it's going to be both over the ATF, the calcaneofibular ligament, maybe at the 5th metatarsal head. They're going to start getting ecchymosis, which is called swelling, that black and blue discoloration you can see there in the foot. Then we're going to have positive stress tests, which I'll talk about soon. And when they walk, it's actually going to hurt. Now it's going to be painful for them to walk. Again, we're going to do the same kind of treatments we did before on the lateral grade 1. Price, probably going to have to put them up on crutches. And I typically would send them to get an x-ray just to make sure they don't have a fracture. Anytime somebody can't weight bear, I think they should get an x-ray to rule out any kind of fractures. That's my particular philosophy of providing care. So grade 3, here's a picture of a grade 3. You can see that it has a lot more swelling than the grade 2. All the way down in the foot is fat. They're going to have severe pain, swelling, and point tenderness all over the place. A lot of discoloration, the echomysis. They may have some deformity here because they may dislocate something. And they probably can't do any weight bearing, or if it is, it's very painful. And here we'll have a positive stress test. We do the same things we do with the grade 2. We're going to send them to get an x-ray because more likely they have a fracture. They're going to go see an orthopedic doctor, get an MRI, and from there we'll start working on rehab if they have to have surgery. So let's look at some of these stability tests or stress tests or special tests. There's same thing, same term meaning the same thing. So the first one is the anterior drawer. When I go over the how to do the lab component of this, I'm going to go over these again. Anterior drawer test. It tests the anterior talar fibular ligament and the calcaneal fibular ligament, and we stabilize the lower part of the tibia and the fibula. We cup the heel with our hand and draw, like opening a drawer. That's why it's called an anterior drawer test. We draw the foot forward, and a positive test, that means that whatever we're testing, that's not a good thing. We don't want positive tests medically. We want negative tests most of the time. Is the talus, you can actually, the foot will slide forward when we're doing this test. That means there's laxity, and that means the ligament's gone. So if it's completely torn, it will just slide forward. You can actually hear a clunk or feel a clunk, and pain. Pain is a positive sign too. So that is for an anterior talar fibular ligament and calcaneal fibular ligament. The talar tilt test tests the calcaneal fibular ligament and the ATF. So we have, as the picture shows, have their ankle off the table. We stabilize the lower leg. See the arrows pointing down, and we invert the ankle or the foot. And the positive test is the talar tilts, which there is laxity. It actually opens up more than the good side. And again, pain is another positive test, a positive sign for this test. Eversion ankle sprains, not very common, because our lateral malleolus extends further down than our medial malleolus, and the deltoid ligament is very strong. And that eversion motion is just not very common. You got a lot of stability if you think about just trying to evert your ankle. It just doesn't, there's not a lot of motion in that direction. So it's not very common, so I'm not going to spend too much time on that. But if you do have it, if somebody does evert their ankle, you're probably going to have some kind of fracture called a avulsion fracture of the tibia before the deltoid ligament ruptures. Okay, so if somebody does this, they probably have a fracture, and then treatment's going to be priced, but you're going to probably have to go get them an x-ray and they're going to have to go to an orthopedic doctor. Ankle fracture or dislocation. So this is a kind of a gross picture of an ankle fracture and dislocation. So my philosophy again is anytime an athlete has a grade 2 or greater ankle sprain, I think they're going to have a fracture, so I just send them over, get an x-ray. We're going to have a positive bump test, positive compression distraction test. Going to have some kind of deformity because that ankle in that picture is not going anywhere. Extreme point tenderness and pain and swelling. So let's, here you're mobilized. We talked about the splints earlier in this class, and they're going to have to go to, I would call 911 and get them to the doctor. We got to make sure that they have a distal pulse in their toe, make sure they have sensation down in the toe. I would take their shoe off, I would keep their shoe on, and get it, call the paramedics and have them go to a hospital and get x-rays and do all the stuff that they need to do down at the ER. So tests for fractures, the first one's called the bump test. This is for the lower leg and ankle. So with the person's heel, they lightly bump the calcaneus or the heel of their foot lightly first. Not too hard when that first happens. What you're trying to do is cause vibrations to go into the bone. So if you're barely touching it and it hurts, they probably got a fracture. If you continue to do it until you hit it pretty hard. If you're hitting it fairly hard and it's not causing a lot of pain, they probably don't have a fracture. The compression test is where you push the tibia and the fibula together. Again, you start away from the side of pain and work towards the side of pain. So if they have a lot of pain when you're way away from their ankle, for example, and they have a lot of pain up there by the knee, that's a positive test, and just stop doing it from there. So again, sometimes you just got to use common sense when you're taking care of people. Okay, lower leg injuries. We're going to start with Achilles tendinitis. This typically is caused by overuse and doing more and more and more, a lot of practice, a lot of playing. Maybe you have gastrocnemius soleus, lack of gastrocnemius soleus flexibility, the Achilles tendon, or poor biomechanics. What I mean by poor biomechanics is maybe you have a leg that's longer than the other. You have one of the arch issues that we talked about early in class. Got something weird going on with your feet, your toes, your knees, your back. Something's wrong. You're not mechanically correct. So we have a lot of signs and symptoms for this injury. Again, we have the pain, swelling, and point tenderness of tendon. The tendon will be thicker, as they're shown in this picture here. The left Achilles is much bigger than the right Achilles. When they're doing hills or uphill workouts, that really hurts. Doing a hill raiser is painful. When they first wake up in the morning, or if they've been sitting for a while, it's very stiff, hurts to move. And when we touch it, it's really hot because that's inflammation. It's one of those signs and symptoms of inflammation. We can actually, if I touch the tendon while they're doing active dorsiflexion and plantar flexion, I can feel or hear a cracking. That's not a very good sign. That would be, this person in the picture there probably had a crepitus, as it's called. And when they move, when they have active plantar flexion, stepping down, that is painful. And if I stretch it in passive dorsiflexion, that's very painful. It's pretty common, this injury. I mean, common that people know what they got going on, meaning that common in that I think I have Achilles tendonitis. So our treatments here, heel lifts. So here's a heel cup, and what that does is puts the gastrocnemius on a slack and allows the calf to relax. It works. Don't know quite to understand why, but this does work. If they have some kind of biomechanical flaw, you got to get that fixed with orthotics typically. Cross friction massage, what we do with this, if we think about, hit the wrong buttons. If we look at this picture here, I would have this person lay on the table with their feet hanging off the table. I would get some lubricant and go across the tendon very rigorously with a 2 to 5 minutes in a massage motion, working my way towards the heart to try to restart the inflammation system or inflammation cycle again. So the body will start healing itself again. It's very painful, but it works. Sometimes the person may get a cortisone shot there. It's not the best place to get a cortisone shot, but that might be the last resort. Anti-inflammatory medications too, the typical ice, rest, all the price things that we would do. The one they're going to have to do is they're going to have to take some time off because this is a very difficult injury to heal from. Achilles tendon rupture. This is common in athletes over 30. And this happens when you suddenly push off with the foot and fully extend the knee. This happens all the time in everything you can think of. The person feels a sudden snapping feeling, immediate pain that goes away, and they have severe pain, swelling, and point tenderness. They will have deformity down there by the Achilles. I forgot to show a picture of the Thompson's test. I'll do that in the lab. This one here is they got to mobilize and get them to an orthopedic because they got to have surgery. So muscle strain is pretty common to the medial head of the gastrocnemius. So that would be on the inside of your leg, up there, topped by your knee. My wife's cousin just had a muscle strain like this, but it was to another muscle up there. I thought he tore his Achilles tendon, but it was actually a popliteal muscle in his posterior knee. He did this quick stop with foot planted and suddenly extend the knee. So tennis, this is a tennis move. We running forward, quick stop, and stand up, extend the knee. That will do your muscle strain. You have a painful heel raisers, so you lift up with your heel. The other one is they feel like they were hit with a stick in the calf. I've had people tell me this when they've done this injury. I was running and all of a sudden I feel like I got whacked in the back of my leg. So a lot of ice, a lot of treatment here, heel lifts in their shoes with this particular injury. Next, lower leg injuries, acute compartment syndrome. And remember, we talked about the 4 compartments. This typically happens in the anterior compartment. They get kicked in the shin really badly, and it causes swelling in the compartment. Again, we have a lot of blood vessels and nerves inside the compartments. And again, it usually happens in our anterior compartment because that's right in front, especially in soccer. That's why they wear shin guards, to be honest with you. That's one of the main reasons why it's for this particular injury. So our signs and symptoms are drop foot. That means they just can't hold their foot up. When they walk, they just slap their foot down. Pain on passive, which means stretching stretching with plantar flexion. Weakness with dorsiflexion and toe extension. They may have numbing and tingling of the webbing between their first and second toes, the daddy toe or is the big toe and the second toe, because that's where those nerves are going. That's where they're sending the signal to, is to those toes. Treatment here, ice and elevation. We don't want any compression here because it's already being compressed. There's a bunch of swelling in that area. We got to get rid of that swelling. We use a lot of ice cups with this one because we don't want any more compression going on there. And if the signs and symptoms don't go down in 72 hours, you may have to get them to a doctor. I've never had this happen where they actually have to open up the lower leg to get the swelling out of there, but that can happen. So it doesn't happen a lot. And again, I've never seen it, but it could happen. Next one is medial tibial stress syndrome. This is also known as shin splints. Again, this is a catch-all term for any kind of anterior medial lower leg pain. Sometimes this could be a stress fracture of the tibia. We really don't know why it happens. Some of the reasons why this may happen is that the shoes that you're wearing don't have really good support, especially the arch support. Could be because you have really weak lower leg muscles. You've been running on a lot of hard surfaces for a while, basketball, track and field, or track and cross country. They switch running surfaces from being on soft grass to the track itself, and maybe that track is really hard. We have tight Achilles tendons, and again, the biomechanical flaw combined with overuse. This is a chronic injury. This is an injury that takes time for it to happen. Our treatment here, there's different levels of pain here, the grades of pain. We may need to get them to the doctor. They may need to rule out a stress fracture. We need to figure out what that problem is and fix it. That's orthotics. Sometimes that's the only way you can fix it is with orthotics. We use an ice massage here. Ice massage is you get a wax-lined cup, fill it up with water to 75%, 3/4 full, freeze that thing, turn it into an ice sickle, cut out about half of the paper or the cup, and massage your body part for about 15 minutes. Anti-inflammatory medications. This is an area that I don't think I've ever seen anybody get a cortisone shot for, because we don't know exactly where all the pain's at. So anti-inflammatory medications are ibuprofen or Advil or Aleve, those type of things. The thing with those medicines, you have to be consistent on taking them. So you have to do the 2 every 4 hours, like it says on the doctor will prescribe to you. This is where the arch support tape job or a shin splint tape job is very helpful. Lower leg fractures, as you can see there. This one is call 911, keep them stabilized, and make sure that they have a blood flow down into their foot. You touch their foot, make sure they can feel that. This is immediate 911. Get somebody there to help you. Okay, so quick review. We talked about how to prevent ankle and lower leg injuries. We talked about lateral ankle sprains. And the MOI for plantar flexion and inversion involves all three. I should put all three lateral ligaments: the anterior talofibular ligament, calcaneofibular ligament, and the posterior talofibular ligament. With inversion, that's primarily the dorsiflexion. Sorry, I got that messed up. Sorry, that should be calcaneofibular ligament. That should be CF. Sorry, my bad. Then dorsiflexion is primary our posterior and anterior tibial fibular ligaments. This is the high ankle sprain. Talked about how to grade ankle sprains and the positive, all the different stress tests. We talked about a bunch of lower leg injuries. We talked about ankle or Achilles injuries. We talked about shin splints and lower leg fracture.